Awesome. Well, welcome everyone to the final session of VLC Kickoff, establishing comprehensive prevention and treatment services for people who use drugs. We made it, all things considered. We appreciate your patience with us and for sticking with us. My name is Dr. Isabel Lechuga. I'm the senior manager on the hepatitis team and will be the moderator for this session. I am pleased to be joined by our presenters, Drs. Falade and Talal. This session will provide an opportunity for hepatitis prevention and surveillance staff to get an overview of how providers are supporting access to viral hepatitis care and treatment for people who use drugs, and to create a space to discuss types of partnerships between health departments and clinical providers serving people who use drugs. Presenters will provide a brief overview of their specific clinical work, including removing of barriers to access hepatitis care and treatment. And we will begin with presentations from Drs. Falade and Talal and have allocated time at the end for a Q&A. Feel free to use the chat box throughout to ask questions and comments. And thank you to NASTAD staff. I see Alex, thank you so much for supporting this session. So we will begin with Dr. Talal. If you can please introduce yourself along with your title and affiliation and get us started.
Thank you very much for the, can you enable sharing?
Yeah.
It says host disabled part. Anyway, I'm Dr. Andrew Talal, professor of medicine at the University of Buffalo. And I've been treating patients who use drugs primarily in methadone programs for almost a decade now, and I'm still not able to share Isabel.
Terry, can you help with that? It's not coming up on my end.
Yeah, I just...
So the title of my presentation will be Patient-Centered Integrated Telemedicine for Treatment of Hepatitis C and Opioid Treatment Programs. And now I can, okay, great.
Awesome.
And so I will put this, okay, great. So the conventional mode for hepatitis C treatment has been the offsite referral model, where providers are limited at OTP programs. And for a variety of reasons, there are barriers to treatment when one is referred to a liver clinic. And these barriers can include stigma associated with hepatitis, with substance use, lack of knowledge about HCV, competing priorities, and limited or no insurance. And indeed, when we asked people several years ago in a methadone treatment program, how many were willing to receive treatment? Indeed, 78 said they would be, but only about 5% actually do receive treatment. So several years ago, we asked the question whether HCV facilitated telemedicine model could be used to bring the HCV provider to a familiar and comfortable environment for patients, and thereby parachute in the hepatitis C provider into the opioid treatment program. And at the same time, and it's demonstrated here, the provider has access to the EMR from the site. Our model is quite straightforward, as illustrated here. Patients are screened at the OTP for hepatitis C. Those who are HCV RNA positive then undergo an evaluation with a physician extender at the opioid treatment program. One of the benefits of working in New York State has been that all OTPs do have physician extenders. They then, via telemedicine, the hepatitis C provider is then parachuted in or linked in. And finally, all blood work can be done on site. This is especially much easier now that we don't require liver biopsies. And the hepatitis C medications can be ordered and delivered to the methadone program to be dispensed with methadone. And obviously, we repeat this until the end of treatment with single dose tear packs for easy administration for days when patients don't come to the methadone program. Results of our pilot study were published a couple of years ago. 45 patients enrolled at one site were treated for hepatitis C. 93% were cured of HCV via telemedicine, as was covered in this article published in Clinical Infectious Diseases a couple of years ago. And in a separate publication, we looked at patient reaction to telemedicine for clinical management of hepatitis C, and 95% recommended this modality over in-person referral. And indeed, these data served as the basis for an award that was for a 5-year project that was commenced in 2017, funded by the Patient-Centered Outcomes Research Institute, to evaluate hepatitis C treatment integrated into opioid treatment programs via telemedicine. So we recruited patients over a 3-year period, and I'm pleased to say that recruitment was completed exactly 2 weeks before COVID. So thankfully we were not impacted significantly, at least in recruitment, by COVID. We recruited over 600 patients. 12 sites across New York State were represented and covering most metropolitan areas, 2 here in Buffalo, 2 in Rochester, 1 in Syracuse, 1 in the Hudson Valley, 60 miles north of New York City, and 6 in New York City, 5 in Brooklyn, 1 in Manhattan. And in our case, telemedicine removes time and places obstacles from delivery of high quality, cost-effective healthcare, and really permits providers to treat patients statewide from the same location. So I can sit in my office and in the same morning see patients here in Buffalo, in Syracuse, and in Brooklyn without ever leaving the same physical location. While the primary outcome has yet to be published, I did want to highlight a couple of publications that have come that I think are from this work that I think are especially relevant. One which was published a few months ago in the Journal of Biomedical Informatics. This is the graphical abstract, describes how we established a statewide patient-centered telemedicine network using something called the socio-technical system model. And really in this graphical abstract, as you can see, there are 8 domains that were considered. The 4 in orange are really those that are easily achieved by technology nowadays, and those in blue, namely the clinical content, the interoperability of healthcare of EMR systems, measuring and monitoring. How do we determine a quality health exam? What are some of the codes that could be used to bill for that? Those should be different than those that are used for in-person. Internal organizational features and workflow and communication aspects really require future work. And we're looking at some of these aspects in future work that come from this work. Another paper that was recently published in the Journal of Substance Abuse Treatment looked at how the facilitated telemedicine model promotes confidence and trust in virtual healthcare delivery. And this really was facilitated by the trust that patients already have in their opioid treatment program. We asked case managers to report those features that they thought were the most important, and we found that building trust, assisting clients in overcoming competing priorities, and delivering personalized care approaches really facilitated the engagement of participants first and foremost in research, in clinical care for HCV, and finally within telemedicine. And finally, I was asked to discuss the sustainability of the model or how it might be scaled. And in our case, the PCORI study required participants to have insurance, and indeed 95% of those individuals in New York State who are in methadone do have insurance, mostly state Medicaid. And we were able to, the study paid costs that were not typically covered by insurance. We also set up a collaboration with Abbott Laboratories for HCV testing. But really the sustainability and scalability of the model will require likely a Netflix model, which is currently operative in Washington State and Louisiana, where a coalition of state stakeholders pays one lump sum for unlimited access to HCV medications. And the Smart D program through state Medicaid may be another alternative, as has been used, at least in the case of Washington State. So in terms of conclusion, I hope I've shown you that engagement of vulnerable populations in research and clinical care is feasible and is highly valued by both the participants as well as the sites in which the research took place. HCV treatment via integrated telemedicine alleviates many healthcare obstacles encountered by vulnerable populations. It's a patient-centered approach to healthcare delivery. It's convenient and preferred by patients. And perhaps most importantly for this population, really, we have found remove stigma as we've discovered through patient interviews that are currently ongoing. And I hope we will be showing that it does remove patient burden and improves quality. And finally, I'd like to thank all the people who have participated in the trial, and thank the sponsors, PCORI and the Kaleida Health Foundation. And most importantly, thank NASTAD and the organizers for the invitation to speak to you today.
Great, thank you. Dr. Falade, you ready?
Yes, I am.
All right, can you? Yes, it's ready.
Okay, fantastic. Thank you, Dr. Talal, for such a wonderful opening. My name is Falade. I am an associate professor in the Division of Infectious Diseases at Johns Hopkins Hospital and the university. I also want to say thank you to the organizers for this opportunity to discuss some of our work in Baltimore around patient-centered models of hepatitis C care for people who use drugs. So what is happening in Baltimore? As some of you may know, Baltimore has been a hotspot for a number of years for substance use. We also have a cohort called the AIDS-linked intravenous experience cohort, and this has followed people who use drugs in Baltimore for over 20 years. The data I am showing you is the care cascade among people who inject drugs who were recruited from the community in Baltimore between the years of 2015 and to 2018, so relatively recently. And you see that amongst these 418 people who use drugs who had confirmed hepatitis C infection, 96% had been tested, which I think is amazing. And that is a testament to work done by multiple people in different sectors, the community, universities, CBOs, churches. Routinely, we have programs where free testing, and in particular, rapid testing is available in the community so that wherever you feel comfortable, you had the opportunity to get tested. And we also see that 75% were aware, which is much higher than the national average. And I think a lot of this is driven by the fact that we're using testing modalities that make it possible for people to get access to their test results the same day they get their testing done. Unfortunately, the big drop-off is when it comes to evaluation, with only 23% of these individuals evaluated for hepatitis C, 17% treated, and 13% cured. When we looked at individuals recruited in 2018, the number had gone up a little, but again, only 16% had been cured. And we're all aware that the magic number to achieve hepatitis C elimination is an 80% rate of treatment, with the understanding that majority of these individuals will be cured because our oral direct acting agents are just so excellent. And so I see this as an opportunity to increase hepatitis C testing and treatment uptake amongst people who use drugs. And I think that it's critical that as we design these interventions, we are taking into account the lived experiences of people who use drugs and people who have hepatitis C. And so in this study, we recruited patients, clients at opioid treatment programs and tried to assess the care cascade. Now, the bullet point is 20% of these individuals had been treated for hepatitis C. We wish we had programs like Dr. Talal's in Baltimore, and numbers probably would be higher. But I think key things to take away was that one, recent drug use was still a barrier to treatment. So we need to think about our patients that are still using drugs and think about ways to engage them and support them to complete hepatitis C treatment, because that population is going to be critical to reducing the reservoir of hepatitis C if we're going to eliminate infection. And I think of note were two things that the community shared with us. One, peer support would be important to facilitate linkage and engagement in hepatitis C treatment. As human beings, it's always helpful to have someone on your side supporting you. And in addition, treatment at places where individuals were already accessing care and felt comfortable accessing this care was identified as a facilitator to hepatitis C treatment. Opioid treatment programs in this case was the place identified by patients in this study. We all know that one of the key barriers to treatment is having providers available that can treat. An option is making those providers available via telemedicine, as Dr. Talal presented. Another option is expanding capacity of providers in a broad range of settings. And so I'm very excited to have been a part of Sharing the Cure program led by Dr. Rita at Hopkins, which was initially funded by the CDC. The funding went to the Maryland Department of Health, and we at Hopkins worked worked on the component of the grants, providing training to providers in the community. The training was provided via telemedicine, and in many ways was a learning collaboratory where we took providers in multiple different settings, including primary care offices, opioid treatment programs, in jails and prisons, and providers worked together to learn how to provide hepatitis C treatment by sharing their cases, getting feedback, and then receiving ongoing consultation from people with more experience providing hepatitis C treatment. Over 600 people have received hepatitis C treatment and been cured in multiple different settings through this initiative. As we think about meeting people where they are, we need to think outside the box. Where do people who use drugs access care? One of those places are local health department clinics. In Baltimore, we have 2 sexually transmitted infection clinics, and I can share that 20 to 30% of the patients that access care at these settings are people who use drugs. And in 2013, with the support of a CDC Foundation grant, we were able to implement routine rapid hepatitis C testing for everyone who came into the clinic. And I think that was critical in reducing stigma. And I think right now with the changes in the guidelines for testing, we're really positioned to be able to take away the stigma associated with hepatitis C testing by routinely offering it to everyone, regardless of risk factor or demographic. This testing was offered by a patient navigator, and that was critical. We got that feedback both from the community and also from providers who had experience working with this population related to HIV testing and linkage to care. The patient navigator offered the testing, did the rapid testing, which typically took 20 minutes for the results to come back, which provided an opportunity to have a discussion about hepatitis C, the availability of oral drugs that could cure infection. And because it was a rapid test, individuals got their results before they left the clinic and had the opportunity to get the follow-up blood draw at the lab in the clinic. They got an appointment to come back 1 week later for their HCV RNA. And if they didn't show up, guess what happened? They got a call from the friend they made while they were waiting for their rapid test results and were encouraged to come back. And if they still did not come back, we had the ability to do community outreach. This program has since expanded to a citywide hepatitis C linkage to care program where disease intervention specialists at the Baltimore City Health Department offer services to anyone in the community to help individuals with hepatitis C linked to treatment at multiple settings in the community. Again, giving access to services where people feel most comfortable accessing that services. Another place people who use drugs access care are syringe service programs. The Baltimore City Health Department, in collaboration with Johns Hopkins, has this program where we have a spot van, and we refer to it as care on the spot, where the van is parked close to the syringe service vans. Patients can get their needles and syringes and immediately walk onto the van. They have access to HIV testing, hepatitis C testing, access to HIV, hepatitis C treatment, wound care. And the idea is that people are not one disease. They have a broad range of needs. And as much as possible, we want to be able to meet as many needs in one place. And that's really what the Spot Van, which is led by Amanda Rosecrans, who you see on the slide, does. It provides non-stigmatizing, patient-centered care on the spot. The next plot is us trying to be like Dr. Talal and provide telemedicine in collaboration with syringe service programs and local health departments in rural parts of Maryland. As you know, rural areas of the country have been hit hard by the opioid epidemic. And unfortunately, these areas have the list in terms of specialists and specialist services. Working in collaboration with the Maryland Department of Health, we now have a program which offers both hepatitis C treatment and substance use disorder treatment via telemedicine at 3 SSPs/local health departments in rural Maryland. There's a lot of thought that has been put into what is the best model of care. The HERO study is a multi-site trial, which I was fortunate to be a part of, led by Alan Litwell, which looked at 2 models: direct observed therapy, which has been done for many years in New York at opioid treatment programs, where patients can go to the window and have their hepatitis C medication intake observed. There was also the option of a video, which was taken by the patient to show that they took their medicine versus patient navigation. The long and short is that both models were effective, but I think for me, most exciting was that implementing the study at opioid treatment programs in Baltimore actually led the OTPs to take on ownership of hepatitis C treatment, so that the OTPs, we worked with the OTPs to implement hepatitis C testing and treatment by providers in the OTP, which again gets to providing non-stigmatizing care in places where patients feel most comfortable. I cannot say enough about how critical it is to engage the communities that are affected by and who use drugs. As part of my care of hepatitis C, I routinely talk to my patients about talking to their friends. And we had a pilot study in which we invited patients who use drugs, who were accessing hepatitis C care, to talk to their friends and link their friends to hepatitis C treatment. And this is a quote from a person who uses drugs and was actively using drugs and continued to use drugs during treatment. This is what he said: "I took the meds, I got cured, and I started telling everybody about it. It just seemed like it uplifted me a little bit. And I was smiling about it. I know a lot of people I did drugs with knew they had it, but they didn't know about the cure. I will tell them about it. That felt good." We, through the partnership with people who use drugs, not only engage people that we otherwise would not be able to engage, but also give people that don't often have an opportunity to give back. Thank you very much.
Great, thank you. So we will begin the Q&A discussion. But first, Doctors Talal and Falade, do you have questions for each other?
I thought the cascade was very interesting, the one you showed, and I assume that's the Alive study before. Is that what has?
So these were individuals that were newly recruited into Alive between 2015 and 2018. So essentially a community-based cohort of people who inject drugs in the oral DAA era.
Because I remember that I've seen that has been shown by Shruti Mehta, that like from 2008, I remember her paper. So have there been, has that been updated yet in terms of how, I mean, is it still 13% SVR or has?
So this is very recent data. This is from 2018. So the old data was prior to oral DAAs. This is very recent data. And in 2018, the rate of cure was 16%. And so what has shifted is that we now have many more people that are aware, but we still have that huge drop off from awareness to treatment.
And that's what you're trying to do with all of these interventions, really. I mean, you have a multi-pronged approach, so which is interesting.
Yeah, and like I shared, like this is work being done by multiple people, but again, I think for all of us, on this call, it's all about trying to reach everyone wherever we can, right? This is, in line with the theme of health equity. How do we give everybody the best possible chance of having the best possible health? And for some populations, due to certain disadvantages, it's just going to take more than having specialists waiting in the clinic to see patients, because a lot of these patients will not come to see the specialist in the specialist center for some of the reasons that you identified in your talk, Dr. Talal.
Thank you.
Can I ask a question? Around expanding access to hepatitis C treatment, with the telemedicine, have there been challenges with billing and reimbursement? One, to you, and then two, are there ways that the OTP might be able to, get back some monies for the efforts they're putting in around testing, staffing to do case management, those kind of things?
Yes, so the billing is done on a state-by-state level. So and we are actually, we'll be looking at, we have collected all of the revenue data in terms of the billing for telemedicine, and so that we were reimbursed. And there is a facility fee that can be provided to the methadone programs. When we looked at this 4 years ago in 2017, it was quite low. And many of the OTPs decided that it wasn't even worth, it was few numbers of, it was few numbers of patients. So 13 patients per 9-month period. So it was, not that many evaluations and so many of them felt it wasn't worthwhile. But one of the ways in which we're thinking about pursuing that is as we publish the evidence base, then we can request the appropriate reimbursement. Because another aspect would be, and it's modified DOT to have the medication then dispensed with methadone. So you can get the program should be able to be reimbursed for medication dispensing. I think at least in New York State, when I looked at this, you could only, the Hep C medication couldn't be reimbursed on top of the already dispensing the methadone. But that's something that I think with some discussion probably could be addressed. I would hope it would be favorable, but as we know, these things sometimes take a long time.
Thank you, Dr. Talal.
Thank you.
So, because our audience is primarily health department staff, I want to shift gears a little bit and discuss basically how can a health department approach you? What are some opportunities for collaboration? For example, can a health department speak to Medicaid, etc.?
Yeah, I think health departments just have so much potential, and we learned a lot from our hepatitis program. So we went from implementing the program with the Cities Foundation grant to thinking about ways to sustain it, and very quickly had to learn how to use patients' insurance and bill insurance for the laboratory testing. For hepatitis C treatment, unfortunately, because we still require a prior authorization to be able to get prescriptions filled, that was something beyond the health department we worked in, and we were able to identify a pharmacy that would partner with the local health department and put systems in place to get the documentation required to submit the prior authorizations, and also put systems in place to ensure that we were working with the patients to figure out the best way for them to access their drugs. And that varied. So there were some patients that could go to the pharmacy and pick their drugs. There were other patients that were less stably housed and consented to the medications being shipped to us at the local health department, and then they would come in to pick the medications from us. And I think, the local health departments are very special because you know your population so very well. And are so well positioned to meet their needs. And in terms of, are there opportunities to collaborate and support? There are many of us, at my institution, and I can imagine throughout the country, that have worked with local health departments that would be happy to provide consultation.
Wonderful. How about you, Dr. Talal?
So in New York, we're fortunate that since April, prior auths have been eliminated. So that and access, I'm a hepatologist, and it used to be that only gastroenterologists and infectious disease physicians could prescribe. That has been removed. As part of the study, I did want to have it be paid for by insurance. And so we partnered with a specialty pharmacy in New York City that did all of the prior auths and was responsible for repackaging the medications, as I said, so that it was easy for the nurses in the opioid treatment programs to tear off strips and deposit it as they're already preparing the take home. Somebody's not coming in on a weekend, they just put in 2 extra medications for the Hep C or whatever the pickup schedule. And that actually worked well during COVID because attendance requirements were relaxed phenomenally during COVID, especially in New York City. So we've been able to so I think there are opportunities, and we've worked closely with both the New York State and City Departments of Health in terms of thinking about sustaining the project, and have had other, I chair a work group, a statewide work group that has meetings, bi-monthly meetings in which we discuss telemedicine implementation. We've developed a telemedicine implementation guide that is on the NASTAD website you may be familiar with. Batima helped us with that about a year or so ago. So we do have in fact, NASTAD has resources we've partnered with to expand telemedicine reach.
Thank you for the plug.
Sure.
Okay, we have one more question from Thaddeus. Thaddeus would like to hear more about revenue data for mobile medicine reimbursement, as they are also exploring requesting billing codes for street medicine at CMS with the Street Medicine Institute in California.
So I think that the telemedicine, whether it's done, and one thing I was going to mention was the health departments and advocacy in general can be very helpful in keeping the benefits of COVID-19 in place. And when the pandemic was created, there were a whole variety of factors. I mean, telemedicine moved 3 to 5 years into the future. So there were many regulations that were done away with. And one of those was, in many states, were the need for an in-person evaluation at first, or doctors to be licensed in the states. So a lot of these have been lifted, and that's a place where I think we have regulations that are archaic. And I mean, I'm no longer required to give a PPD every year. I needed to give a PPD. How many people transmit, tuberculosis via telemedicine? So I think that's one place. And in terms of, and with that, the reimbursements for telemedicine have really been liberalized. And I expect that as broadband is increased, I mean, as part of the bill that was approved by the Senate today, broadband access should be expanding. This is a real need in rural areas. Advocacy should be done around expanding telemedicine access and removing unnecessary restrictions, in my opinion.
Perfect. Okay, well, we have, I think this is time. Unfortunately, it's evaluation time. So I've pasted the survey link in the chat box. If folks can please fill it out. And is it okay to share your contact information? I can also have folks email us, NASTAD, and I am getting some direct messages if they want to speak to you further. So if that's okay.
Yes.
Well, this is it. And I want to express my gratitude to both of you for making time during the status quo for us and for your comments and for your work. So that being said, if there are no other lingering, I think we're good, right? Amy?
Thank you very much for the invitation.
Yeah? Awesome. Appreciate it.